Omer, okay.
Hi, hello everybody, dear friends. Let me share. Yes. Do you speak? Excuse me. Do you see my?
Yes,
Yes,
very
yes.
nice.
Okay. This is a very good opportunity to share our experiences among us. That's why I would like to thanks to organizing committee for inviting me. This topic, yes. This topic is clinically is very important because still we can see some problems regarding the source of the differential diagnosis of leg pain. Osteoarthrosis is a very common disorder, especially in elderly population. And this problem is a degenerative process of the joints rather than an etiology-based disease. Osteoarthrosis can be seen in all synovial joints of the body, but spinal column, knee, hip joint, and small joints of hands are commonly affected. However, it's not uncommon for arthritic changes to be seen radiologically, but not always clinically significant. Also, this observation is particularly valid for spinal degeneration. We saw in the presentation of Dr. Zilali. Changes to be seen radiologically. Spondyloarthrosis, degenerative spondylolisthesis, or degenerative disc images on direct X-ray or spatial MRI cannot always be accepted as clinically important. In another word, these types of patients sometimes can be asymptomatic. In daily practice, you can see these types of patients very frequently. You can see significant degenerative changes on plain X-rays, CT scans, and MRI, but clinically the patient has no major symptoms, as you see, and does not require surgical intervention. Tandem osteoarthrosis is very common in population, but its importance is not sufficiently stressed. This clinical entity is a systematic disorder. Osteoarthritis generally affects cervical and lumbar area simultaneously, and it's not so easy to distinguish which complaints originated from cervical or lumbar segment. Hip and knee arthrosis are commonly seen with degenerative spine disorders. There are some risk factors for tandem arthrosis, such as genetic predispositions, weightlifting or heavy laborers, elite athletes, obesity, or some strict diets, and smoking. This is the first paper which has been stressed systematically the hip spine syndrome. It's published in Spine in 1983. The authors have found 35 cases in their patient series. They have divided their patients into 3 categories. If only one of the spine or hip joint is symptomatic, it is called as simple hip spine syndrome. In these patients, clinical findings and diagnosis were straightforward and belonged to only one area. The patients may have some radiological findings, but if there is not any complaints, it's accepted as insignificant clinically. In complex type, complaints originated from both sides, and this type is confusing the clinical picture. They have reported 4 cases with misdiagnosis. 2 of them were operated on from hip joint, and the other 2 were operated from spine. Clinical pictures were worsening after the operations, and second surgeries were required. And the last type of the patient group is named as secondary type. In this type, the patients have spine symptoms, but clinical pictures are aggravated by the deformity of the hip joint. This paper is very important because it's published in 1983, but still there are a lot of misdiagnoses between hip and spine symptomatology. Here is an example of a patient with he's a 68 years old male patient. He admitted to the hospital with leg pain for 3 years. His pain was increasing by walking and standing. The walking distance was about 50 meters. By the way, you can see significant disc degeneration and spinal canal narrowing on MRI. But physical examination revealed that there is no neurologic sign. Hip joint motions were painful and severely limited. Here is the direct X-ray of pelvis. You can see on the right hip, and you can see on the left hip also. You can see the degenerative deformities at the lateral. Did you see the cursor on X-ray, dear moderator? I think it's not.
Yes, we do. Yes.
Yeah, okay. You can
Yes.
see the degenerative deformities at here. You can see at the lateral part of both joints, and the diagnosis is impingement syndrome of hip joint. For leg pain, the exact question is it's caused by radiculopathy or coxarthrosis. There are some red flags for radiculopathy and hip disorder problems.
Yes.
Okay, do you hear me?
Yes.
Okay. In L4 radiculopathy, the pain originated from low back and posterior aspect of the gluteal area and extend to the lateral sides. The tight pain is generally radiates from sacral or low back area. The extension power of knee joint may be diminished. The patients may explain from seeking sensational problems on the dorsal part of the foot. But in hip problems, the pain is generally located at the anterior part of the groin zone. The pain almost always increases during weight bearing, such as walking or running, and the flexion contracture of the hip joint, generally usual finding. Here is the clinical pictures of radiculopathy and hip pain, radiating characteristics on the schematic drawings. In L4 radiculopathy, the pain originated from low back, as you see here, and goes to posterior aspect of the gluteal area and extends to the lateral and anterior part of the cruris, and generally radiates below of the knee joint. But in L3 radiculopathy, it is similar, but the pain is generally radiating from the low back to the anterior thigh. It's not usual to extend below the knee joint. Hip pain starts at anterior aspects of the groin and extend to the knee joint anteriorly. If a patient describes a pain scenario which is radiating to the foot, it is not possible to cause by hip joint alone. In differential diagnosis, these two clinical scenarios must be kept in mind. One of them is meralgia paresthetica. This is an entrapment of superficial branch of femoral nerve between the fibers of fascia lata. It's generally caused by the clotting habits such as tight clotting. The other entity is the urinary system disorder. Urinary system pain generally starts from the groin and radiates to the anterior and medial part of the thigh and may be misdiagnosed as L3 radiculopathy. It's very similar. Physical examination is the key point for differential diagnosis of coxarthrosis and radiculopathy. In radiculopathy patients, we can detect sensational findings such as hypoesthesia or dysesthesia at the anterior part of thigh. Decreases quadriceps muscle power and patellar reflex loss may be detected. And you can see the Duncan-Ellie test here. The Duncan-Ellie test is generally positive in radiculopathy patients. This test is based on the stretching of the rectus femoris muscle anteriorly with the aim of knee flexion, and it can be positive in L3 radiculopathy. But in coxarthrosis, muscle power and sensational examinations are normal. Flexion contracture of hip joint is a common finding. Patrick's Fabere and here this one and other tests. These are functional tests of hip joint are generally positive. And Duncan-Ellie test is generally negative in coxarthrosis. Radiological examinations are very important for diagnosis and treatment planning. X-rays are the first step exam for coronal and sagittal alignments of the spine. Collimation or narrowed views of coronal X-rays in elderly patients is not suitable, such as this X-ray. So wider view, spinal column, in wider view, we can see spinal column and hip joints together. CT scan and MRI is the key for treatment decision making, but the diagnosis is based both the analysis of clinical and radiological examinations. Invasive tests have a very limited value in differential diagnosis. Intraarticular injection for hip joint is not a widely preferred method because the hip is very deep. Hip joint is locates very deep. It's technically demanding, and the intraarticular piroxicane injection carries additional infection risk for future hip operations such as arthroplasty. Foraminal nerve blocks are more preferable methods than the hip injections for radiculopathy diagnosis. It can be used for diagnosis or temporary treatment of radicular pain. EMG is not sensitive, and generally the results can be changed according to the practitioner's experiences. If there is simultaneous coxarthrosis and radiculopathy and both require surgical intervention, the next question is which surgery should be the first one? There is no consensus in the literature on this issue. Some authors suggest hip surgery should be the first. Some papers revealed that back pain may decrease after hip arthroplasty. The ratio of pain impairment has reached to 66% in the literature. They propose that the hip arthroplasty previously spine surgery may decrease the need for spine surgery. The second reason, hip arthroplasty is more aggressive surgery than the spinal decompression. Its postoperative rehabilitation is more important also. So after meticulous rehabilitation period of hip arthroplasty, may decrease the need for spine surgery. And the third reason is about the biomechanical aspect. Fused spine, especially lumbopelvic fusions, lead to increased axial loads of hip joint. Thus, increased mechanical loads may negatively affect the fibrotic healing of hip joint capsule after arthroplasty. However, some authors are against of this opinion. They suggest that the muscular weakness caused by spinal canal narrowing or nerve root compression negatively affects the hip rehabilitation after hip arthroplasty. Spinal compression is a progressive process, so delays for spine surgery and long rehabilitation period of hip arthroplasty may lead to permanent neurological damage. On the other hand, waiting for hip arthroplasty does not affect the prognosis. Permanent neurologic damage and muscular weakness clearly increases the postoperative hip dislocation ratios. If you look for pelvic biomechanical properties, sacroiliac joint transfers the body weight loads to pelvis in a 14 to 16 degrees, and these loads transfers to the hip joint in same directions. This is a very strict angulation. It's between 14 to 15 degrees from vertical line. If you perform lumbosacral or low lumbar fusion with instrumentation, axial loads of the hip joints tend to become more horizontal than the original form, as you see in this drawing. And if we extend the fusion to the pelvis with lumbopelvic fusion, axial loads to the hip joint become more vertical. This led to asymmetric weight bearing of joint space, and cartilage damage may be aggravated. If a patient has previously mild degenerative hip disorder, it may progress after fusion. You should give information to the patient before spinal fusion operation. In a simple form of hip spine fusion, only the cause of leg pain must be treated. Radiological findings without any clinical compliance may follow up, but surgery should not be the option for only radiological findings, neither for hip nor for spine. As a biomechanical aspect, spine surgery may be the first line option for complex leg pain. It will be less aggressive. However, hip degeneration may be progressed after spinal fusion if exists. Here is an example case. 72 years old female patient admitted to the hospital with low back and leg pain. She had neurological claudication and could walk only around 100 meters. Physical exam was showed no contracture or motion limitation on hip joint. She had severe lumbar canal stenosis. She diagnosed as lumbar stenosis. She was operated and posterior decompression, L3 for interbody fusion with cage, and L2 to L5 posterior instrumentation fusion were performed. Here is the 2 years after index surgery. She had moderate right hip joint pain without motion limitation, but there is hip joint narrowing, but the joint space is quite similar between right and left one. 5 years later, she had significant hip pain and mild flexion contracture. You can see narrowing of the right hip joint. The left one is almost normal, but the right one is narrowed. Because she walking distance was become shorter clinically, but she refused the hip surgery at that time, at that year. because her walking ability was satisfying for her. But at 6 years, 1 year later, her walking distance and hip joint motions were quite limited. You can see the joint space is almost gone, and hip arthroplasty was performed for her. She was happy after 2 surgery and still continues to her life. Another example, 70-year-old female patient. She had severe low back pain and radicular symptoms regarding the L4 nerve root. Radiological exams showed severe degenerative disease and L4-5 spondylolisthesis. Posterior decompression and fusion have been performed to the lumbosacral area. She had hip dysplasia previously, but she had managed with her life without any complaint from hip joint for almost 70 years. 3 years after surgery, her right hip problem aggravated. You see here, there is no joint space, and the chondral layer totally lost during between these 3 years. And this problem solved with total hip arthroplasty. As a clinical aspect, if the hip symptoms are more prominent, arthroplasty may be the first surgery. Spinal fusion affects pelvic inclination due to changes in sagittal plane, so this inclination can rotate the acetabulum and lead to prosthesis dislocation. What are the messages to take home? Hip degeneration is generally accompanied in different forms of degenerative spine disorders. Physical examination is very important for differential diagnosis. Every spine surgeon must know how to do hip examinations, such as Fabry tests, Fader tests, because radiologic findings sometimes may not be compatible with clinical complaints, which may lead to wrong surgeries. Physical and radiological findings should be analyzed for treatment method. The worst one should be the treated first, but if the signs and symptoms are similar, spine surgery may be the first option. Thank you for your attention.
Thank you very much, Dr. Omer Akcali, for your clear presentation. Is there any question from the participant or comment? If no question, we can move to the fourth speaker.
May I say
Yes.
something?
Yes, yes.
This is Dr. Said Naderi from Turkey, Istanbul. I know
Hello.
Ömer very
You
well.
can continue to moderate the session. Welcome.
But nereye gitti bu? Okay. Actually, hip problems is one of causes of hip pain. Not only coxarthrosis, but also AVNs also. I mean, avascular necrosis of the femur head also is one of causes of pain. Therefore, these cases should be examined from the point of view of the pelvis problem. Maybe we can discuss in detail later about the other problems. I mean, sacral problems, sacroiliac problems,
Yes.
insufficiency fractures, deep gluteal syndromes, I mean piriformis syndrome, and etc. But I agree with Dr. Omer Akcali. All spine surgeons should examine hip and also shoulder. As like maybe not as the detail as an orthopedic surgeon, but in order to exclude hip problem, you need to examine hip, and also in order to exclude shoulder problem in case of cervical disc disease, you need to examine shoulder carefully.
Thank you. Thank you.
Thank you. Dear Dharma, I want to say a little bit word. The hip problems generally makes an leg pain, but as you see, I stressed the importance of osteoarthrosis, hip osteoarthrosis, because vascular necrosis or other hip problems such as infections and other things makes too much pain for the patient. The distinguish this type of hip pain from the back pain is not so difficult, but especially mild or moderate level of coxarthrosis generally produces pain to the from the backside to the knee, and these types of leg pain generally is not easy to interpret this type of pain. It's caused from back or caused from hip. That's why physical examination is very important. It's the key to detect the hip problem.
This is also important from the medical legal point of view, because patients may complain from pain of hip, and if you operate in the lumbar spine, in these cases, the pain may exist, and this is problem. In cases with equal pain, also you need to explain to the patient before surgery that lumbar surgery can relieve one part of your pain, and after the surgery, if necessary, maybe 2 months later, 1 month or 3 months later, you may need hip surgery. If you explain it, there is no problem. But if you don't explain, the patient may experience problem.
Yeah, absolutely. Thank you.
Okay. Is there any other question about this or any comment?
May I ask a question? Can you hear me?
Yes, we hear you, Mustafa.
Yeah, okay. So it's for, I had a microphone issue, technological. I apologize. I can voice myself. My first question is for Dr. Akcali. How do you, so it's not actually directly on the topic of hips, but in your presentation, you had lower lumbar and lumbosacral surgical stabilization. I would like you to elaborate on adjacent segment disease, if you could, please. And if I can follow up on that question for Dr. Francesco on the sacroiliac joint and fixation, is mechanical sacroiliac joint instability considered prior to having any medical intervention for sacroiliac joint issues? Thank you.
Thank you, Mustafa. And it's very good to see you here.
Thank you.
The adjacent segment degeneration can be a myth because sometimes, especially for younger patients, when you make a long segment instrumentation, long segment fusion, after 10 years, 20 years, 25, 30 years, follow-ups, sometimes you don't see any adjacent segment degeneration. But in my cases, when I presented, we can accept this coxarthrosis, aggravation of arthrotic changes at hip joint. We can accept them as a adjacent segment degeneration. It's not suitable for lumbar spine upper part of the fusion, but I think it's very valuable for inferior part of the fusion. That's why if you fuse the sacroiliac joint, the hip joint may become worsened. Thank you.
Thank you.